Hello, I'm Keith Barton. The introduction of the Preserflo micro-shunt has made a significant contribution to my glaucoma surgical practice. And in this video I want to share some of my thoughts about preoperative case selection, nuances of surgical technique, and postoperative care. And I hope you find it useful and interesting. I have a number of financial disclosures as I work with many companies. I don't have a specific financial interest in the Preserflo micro-shunt, but I have worked on Santen advisory boards and received speaker honoraria and travel expenses. The Preserflo micro-shunt is a small polymer tube that drains aqueous from the anterior chamber to the subconjunctival space, much in the same way as a trabeculectomy does. However, the insertion technique is rather simpler than a trabeculectomy, and the postoperative care is rather less laborious and less intensive. The micro-shunt itself consists of a 3mm subconjunctival portion that exits the sclera 3mm behind the limbus, so that actually the aqueous exit point is 6mm from the limbus. 1.1mm wide scleral fins that self-retain in the 1mm width scleral tunnel in which the Preserflo is inserted, and a 5mm long intraocular portion. The postoperative course is less intensive, less laborious, and more predictable than a trabeculectomy. The bleb morphology is rather more consistent and better than a trabeculectomy, as the blebs are more posterior and more diffuse, even though higher doses of mitomycin in general have to be used with a Preserflo than you might use with a trabeculectomy. However, as I mentioned, case selection is important, and in general I won't do a Preserflo micro-shunt in a patient in whom I think a trabeculectomy would not work. This includes patients with previous conjunctival surgery, certain secondary glaucomas, if the patients have vitrectomy, silicone oil, etc., neovascular glaucoma. I also find that, like trabeculectomy, subconjunctival MIGS procedures are challenging in higher scarring ethnicities. While it is possible to get Preserflo micro-shunts working in Afro-Caribbean patients, for instance, if they've got virgin conjunctiva and not being exposed to a lot of glaucoma medication, the failure rate is without a doubt higher, but it is for trabeculectomy as well. I'm now going to show a video of my insertion technique that was actually sponsored by an educational grant by Santen some years ago. The technique has not changed a lot in that time, but after the video I will go through some technique alterations and discuss what I might do differently now from what I did whenever I produced this video during COVID. In this video, I will go through step by step some of the nuances of the Preserflo micro-shunt implantation technique. The Preserflo micro-shunt is a fine polymer tube that drains aqueous from the anterior chamber to the subtenon space. The conjunctival and tenons dissection are very similar to those of a trabeculectomy, but unlike a trabeculectomy, do not need to be at 12 o'clock because the Preserflo micro-shunt drains more posteriorly. Lid coverage is therefore easier to achieve, and the potential for bleb dysesthesia is less. I prefer a slightly temporal pruritemy, as bleb problems after trabeculectomy are more common with nasal positioning. Mitomycin C is essential to prevent fibrosis, but good hemostasis is also essential so that blood cannot negate the effect of the mitomycin C. A large pruritemy facilitates posterior placement of the 3 LASIK sponges soaked in mitomycin. After 3 minutes, the sponges are removed and the area irrigated copiously. Reaching underneath the conjunctiva to tent up the tenons also facilitates sponge removal, as sometimes they may get stuck deep behind tenons. The large pruritemy will also be beneficial later during closure of tenons. After light scleral cautery and drying of the area, a mark is made 3mm behind the limbus. The anterior mark should be made close to the posterior edge of the corneal scleral transition zone. This mark is too anterior. This mark is at the posterior limbus, which is correct. This mark is a little anterior, but is satisfactory. A 1 mm wide slit keratome pocket is made as far as the edge of the corneoscleral transition zone, just posterior to the mark. The anterior chamber is entered with a 25 gauge needle, which usually must be bent to achieve the correct angle. The needle is introduced the length of the pocket and tilted forward to enter just anterior to the iris. Avoid distorting the tissues during entry, or the Preserflo micro-shunt may finish up closer to cornea than ideal. A single clean entry and exit without distortion is a critical determinant of the final position. Carefully remove the micro-shunt from its packaging over the eye as it is easily flicked out of the field. The Preserflo micro-shunt is carefully fed bevel up through the pocket and into the anterior chamber. The fins are slightly wider than the scleral pocket to ensure the Preserflo micro-shunt self-retains. Nevertheless, it is important to ensure that the Preserflo micro-shunt is correctly seated. Difficulty inserting the micro-shunt may occur if the anterior chamber is over or underinflated, or if the scleral pocket apex is situated more anteriorly than the anterior chamber needle entry point. As the Preserflo micro-shunt is hydrophobic, it often requires some encouragement, such as scleral pressure, in order to drain. If flow is not visualized during surgery, the Preserflo micro-shunt will not lower IOP. Sometimes flow cannot be elicited with external pressure alone. Ensure the eye is firm by injecting BSS via paracentesis, or here via the implantation tunnel. If there's still no flow, then flush the Preserflo with BSS. The micro-shunt can be flushed easily with a thin-walled 23 gauge cannula. In this case, flow is then easily visualized with fluorescein. When flushing, ensure the cannula is snug against the fins of the micro-shunt inside the pocket entrance. If at first you don't succeed, then flush forcefully again. Take care when closing not to block the Preserflo with tenons. A large peritomy permits visualization of the position of tenons relative to the micro-shunt while closing. I use 210 nylon sutures, which are less inflammatory than Vicryl but may require removal after a couple of weeks. If the tenons is tight, suture in 2 layers, recessing tenons slightly. 8 days after surgery, the bleb is still red, but diffuse, and the pressure is good. Five months after surgery, the bleb is quiet and diffuse. Preserflo micro-shunt blebs are often posterior and diffuse, reducing the potential risk of discomfort and infection. One challenge that we found after some years of implanting Preserflo microshunts was that sporadically patients would develop quite severe postoperative hypotony. This was not very often. It may have been batch related, but it's a little unpredictable. And the patients at risk, I felt, tended to be the patients in their late upper half of their 80s. And for that reason, I'm less likely to use higher doses of mitomycin in that group. For instance, my usual mitomycin dosing is 0.5 milligrams per mil for 3 minutes on 4 corneal shields spread over a wide area in a large peritomy. But for the elderly patients, I'm less likely to use so much mitomycin. It's more likely to be 0.4 milligram per mil, perhaps for 2 minutes. Additionally, I used to avoid high myopes and other patients who are prone to hypotony. But I found that an easy way to mitigate against hypotony was to thread a suture into the lumen of the Preserflo. And there are various ways of doing this, from using what I traditionally used was a 9-0 proline or a 10-0 nylon that's popular. I tend to favour proline over nylon because it doesn't degrade. The next video is one that I made recently with an updated version of my stenting technique. In my practice, I use the Preserflo micro-shunt in patients with progressing glaucoma who are not at a high risk of surgical failure. Some of these patients are, however, at a high risk of hypotony. In order to mitigate against this, a number of techniques have been described that involve the threading of a ripcord suture inside the lumen of the Preserflo micro-shunt. In this video, I'm going to show an update of my technique and the options that I consider when stenting a Preserflo micro-shunt in order to prevent postoperative hypotony. I hope you find this video useful.
Hello, in this video I'm going to present an update of the options that I use to prevent hypotony when implanting a Preserflo micro-shunt. This Preserflo is obviously draining aqueous at a much higher rate than the required 2 to 3 microliters per minute. With a short section of 9-0 polypropylene, less than 2 mm inside the device, drainage is much slower but still adequate. Stenting with a ripcord is a simple method of preventing hypotony in high-risk cases and when there is brisk drainage. First, observe the aqueous drainage carefully after ensuring that the anterior chamber is pressurized. This particular Preserflo is clearly draining too quickly. Here is another case that is draining even more briskly. Use the slit keratome supplied to make a short circumferential peripheral corneal groove. A loop of 9-0 polypropylene is buried in the corneal groove for easy postoperative access at the slit lamp. An anchoring scleral bite close to the Preserflo prevents the device from tenting conjunctiva. In this case, as the slack is reduced on the polypropylene loop, the device is drawn towards sclera. This effect is seen again in this case. This bite is most effective if placed reasonably close to the tube aperture. A scleral bite close to the device aperture also reduces the risk of the Preserflo dislodging on ripcord removal, and this is an important point. It is important also to cut the ripcord cleanly and ideally beveled to facilitate insertion into the small Preserflo. The ripcord is inserted far enough to reduce aqueous drainage without eliminating drainage completely. The 9-0 suture is often quite a tight fit, eliminating flow when only inserted a few millimeters inside the Preserflo. Withdrawing the suture slightly should be enough to re-establish slow drainage. If a very short length of suture inside the tube is a concern, a popular alternative is tenno nylon, which is a less tight fit. Tenno nylon can usually be inserted much further into Preserflo as it results in less resistance. I have tended to favour polypropylene as it is less likely to degrade if the ripcord does not need to be removed. Here's a comparison of the two. Irrespective of the type of ripcord, like the Preserflo, it should be tucked carefully under the tenons before closure. Postoperatively, the polypropylene can be seen through the conjunctiva, as can the loop in the peripheral cornea. Thank you for watching. I hope you found this video useful and interesting.
Subsequent to that, I've also found that tenno-proline can be quite useful, although whether I use nino or tenno depends on how far the stent can be advanced into the tube, because sometimes the nino will only go into the Preserflo a millimetre or two, and there's a risk of it falling out, whereas the tenno can generally go the whole way. On the other hand, tenno can be quite loose and may not produce enough occlusion, so I think you do have to take these on a case-by-case basis. And I generally will leave the ripcord suture in place for 3 or 4 weeks and remove as required. The reason for introducing the scleral bite is that I had one patient who I dislodged the tube after removing the ripcord. The scleral bite therefore prevents that from happening if it's close to the end of the tube. It also, as you've seen for the video, helps keep the Preserflo closer to sclera, so it's less tented up, which is quite good. If the Preserflo fails and the pressure goes up, I'm not a big fan of needling unless it's a very obviously insisted bleb, which most of the time they're not. I do tend to look carefully to figure out what I think is going on. If the tube is clearly patent in the anterior chamber and there's a flat bleb externally, then generally there is a stocking of fibrous tissue around the Preserflo, and this is very hard to remove with needling and likely not very successful. And in that situation I tend to go back in, open up the conjunctiva, reapply mitomycin, dissect away the scar tissue, check that the Preserflo is flowing, and if flowing adequately then close up again, and if not flowing adequately replace the Preserflo. This generally provides some success. Having said that, the success of revising is less than the success of primary implantation, and at times I wonder, would I not be better just moving on to a more definitive procedure such as a tube that's almost guaranteed to work, rather than going through the process of revising the Preserflo and then it might not work, and then this patient still needs another operation, and by that time you're on to your third conjunctival operation. The conjunctiva is shrinking, the patient's more likely to get ptosis afterwards. I think case selection is very important in the first instance. I'm not 100% sure as to whether to revise or do a fresh procedure if one fails, but I tend to revise. I do find the Preserflo very useful in my practice, given the limitations that I've already mentioned, and I hope you find this talk interesting. There are other videos on my YouTube channels that you may find helpful. Thank you for watching.